happy Monday. It is DocSwiner. Come on into the live. We're going to see what I remember. It's been a minute. It's been a minute. Y'all come on into the room. I hope your week is starting off well so far. I hope your new year is going well so far. And we're going to talk a little bit about IUDs. All right. I was triggered. By or inspired by a recent New York Times article that came out about IUDs and how painful and horrible some of the experiences for women have been over the years. Excuse me. And clearly, because I'm a woman, although I don't have personal experience with IUDs, meaning I've never used them, I, in clinical practice, placed them. I was the only person in our clinic that placed them for 15 years. So very well aware of the benefits, the pros, but also the risks, the cons, the side effects, the discomfort that can often come from placement, from having them, and then from the removal of them. But thankfully, not to toot my own horn or pat myself on the back, I generally have very positive feedback from my patient population while doing them, both at UNC and Durham Family Medicine. So even though I'm no longer in clinical practice, it's probably been about 2 years since I've done one of these. It, I think, would be like riding a bike. And those things that I remember that I was trained on way back when at UNC Chapel Hill and Family Medicine, in terms of comfortable placement and removal and all of that, and then what I continue to do at Durham Family Medicine, I think will come right back. And I have some tools that I'm going to use here. So hopefully you're around and you're available. And if you have any questions, you can ask them or make comments in our comment section. But that's what we're going to do today. Okay, so disclaimer. Although I am a board certified family physician, I am not your family physician, meaning any questions or concerns that you have about your own personal experiences, please make sure you talk to your primary care provider about specifically. And also, I'm not here to promote or advertise on behalf of any particular brand of birth control or IUDs. There are many different brands that have IUDs out, so I just wanted to make that clear. I will be saying some names of specific ones that I know that I have used and I have placed for patients, but I'm in no way, an ambassador for any of these brands. So please check with your providers if you have specific questions. All right, let's go. And by the way, if this is your first time seeing me, I'm Nicole Swiner, located in Durham, North Carolina, but I do a lot of things, speaking and teaching and research and all those things surrounding women's health, Black women's health, minority health, pediatrics, OBGYN, all that good stuff. So that's what I do. All right, let's get into it. So I was triggering some folks already with this item here. This is a plastic speculum. They come in all shapes. They come in all sizes. This is kind of a wonky one. These are just demos, but they clearly are also metal and not always very comfortable. So women are very familiar, especially women above age 21, very familiar with these. This is what helps with our exams, with our gynecologic exams, with our pap smears, with biopsies, with placements of things. So many of us are very familiar with that. All right. So what we're going to talk about is, let's talk about what I did in practice to help make placement of IUDs comfortable. Excuse me. And maybe what I should do is maybe even go back a step further and just talk about intrauterine devices in general. So IUDs in general, we use primarily for birth control. They've been out since the copper IUD, probably, again, don't quote me, this is from the top of my head, probably 1970s. I'll correct that. I'll go back and confirm that. But the copper IUD, we've been using since decades ago. It has since gone through multiple variations where either it is copper and does not contain any medication, or it is a brand that has a certain type of medication that is in it to help prevent conception, or for heavy periods, or for really, excuse me, for really painful periods, or for fibroids. There are many different variations, but it's been around forever. And it's gotten a little bit more popular, I believe, because it is pretty much a hands-off approach to contraception, meaning You go in, you have the procedure, your doctor puts it in, you don't have to manage anything, right? So you don't have to remember to take a pill every day. You don't have to remember to go get a shot every 3 months. Like it's, hands off, you're good to go. Most of them last anywhere from 2 years up to 10. And that depends on preference. That depends on whether or not you want to include hormone in it. And that involves if and when you're thinking of conceiving and having children. Sometimes at the end, when you get closer to your 40s, it depends on how long you want to keep it and how long do you want to rely on something that is, quote, external or outside of your body's normal hormonal process and kind of coast into menopause. So there are many different reasons that you should bring up with your provider when you're talking about the different options and what your choices are, okay? Generally speaking, the use of IUDs is very safe, meaning there are not many reasons why a woman couldn't choose to have an IUD. Off the top of my head, I'm thinking, particularly for the non-hormonal copper ones, unless there is an actual allergy to copper, I can't think of why most women could not use a copper form of an IUD. The ones that contain progesterone, like Mirena and Kyleena, unless you have some history of allergy to that hormone, or you have, history of a certain type of cancer or predisposition to a certain type of cancer, you may want to avoid that. I also know that if you're in older age, meaning, 40s and hanging towards the perimenopausal and menopausal phase of life, you may want to think about osteoporosis. The longer that your normal hormonal cycle, which these IUDs can affect, some of them, the longer you are away from that and the older you are, puts you at higher risk for a low bone density because of calcium and osteoporosis and all that stuff. So again, very, complex situation that you want to talk to your provider about so that, once you've done your research, you all can come to an agreement about which one is the best one for you. Great news about IUDs is not only is it a hands-off approach, meaning you don't have to do anything once it's placed, as long as you don't have any complications. The other good news is that fairly easy to remove by your medical provider. I know there have been some people that have talked about removing it on their own at home. Some of my medical colleagues have done their own. And I'm like, I don't know if I would do that. But when you go to your doctor's office, it's a fairly easy removal. And generally speaking, if you are trying to conceive, your fertility usually comes right back. Meaning I have counseled women before to say, all right, now I'm taking this out today. If you're not trying to get pregnant right away, you better switch real quick either to the next thing that we're transitioning to, like you're choosing to do another type of birth control option, or you better use some condoms, point blank, because fertility, it's like a light switch. It comes right back on, which is great because some women are concerned about certain types of birth controls and how they may prevent them from being fertile or able to conceive in the future. So generally speaking, IUD is very safe when it comes to that. All right, let's talk about it. So Mirena, again, disclaimer, I'm not here to promote or advertise for any particular brand, but Mirena is definitely one that I use the most in clinic. It's the one that most women chose for whatever reason, whether it was an insurance issue and they knew that it was going to be covered well, or whether they'd read a lot about it and, thought a lot about it. But Mirena tends to be a fairly, or at least was, times are changing, at least was a very popular option in terms of IUD. As you can see, it looks like a Y, or when it's flattened out, it looks like a T. This is this is a demo, but this is what the IUD itself looks like with the string. This is what's used to place it, okay? Mirena lasts for, they say, up to 5 years, although I have seen some literature that says that it can last another year or two after it's placed. So again, you want to talk to your provider about that. So if you're not rushing to conceive, or if it's going to be a while until you can get back to the doctor to have it switched out, you have a little extra leeway. Brands like Kyleena and other things like it are shorter. I think they're like 2 or 3 years. This is 5 years. Paragard or other copper IUD forms are up to 10 years. which is, again, convenient. All right, pre-medication. So before you come in to get your IUD done, what I would normally do, and this is the way I learned it in residency, was, of course, we have the conversation with the patient. So we talked about their history, their medications, their GYN history. Have you ever had an IUD before? What did you use before? How did you react to that? Blah, blah, blah. So they said, yes, I want the IUD. That's what we want. So we would, in most cases, or actually in some cases, we would actually have some IUDs stocked in clinic so that I could go grab one, make sure their insurance covered it, put their name on it, and then we could schedule to place it. In some cases, we would have to actually place a prescription and it would be shipped to us. So that would, create a little bit longer of a wait before they could get it done. But we would plan ahead and I would say, okay, we have your IUD. This is what you want. Great. Have it in a box. It's for you. You put your name on it. We're going to schedule for, whenever you can come back and do the procedure. 2 things I would prescribe that day. I would go ahead and prescribe ibuprofen, and I would prescribe the 800 milligram dose. And this is probably more for my medical folks than anything, but I would prescribe 800 milligrams of ibuprofen to be taken about an hour before they came in for their appointment. And then they had a couple left over for the days after placement for potential cramping and pain and all that. That's the first thing. Second thing I would prescribe is called Cytotec. And you may have heard of Cytotec being used in labor and delivery when it comes to having babies, because it can help with the induction of labor. What it is a type of medicine, I think it's a prostaglandin inhibitor. It's coming back. Still got it. It is a prostaglandin inhibitor, and it helps the cervix, which is, of course, the donut-shaped end. This is a demo as well. It's not very realistic, but pretend this is a uterus. The cervix is a donut-shaped entrance and exit when it comes to delivery of the end of the uterus, and it is closed, right? Closed. Or in some women, it may have, maybe fingertip opening, and that's what it is. So it is the doorway to the womb. And Cytotec, in the same way that it would help with induction of labor, it helps to loosen up that opening and dilate it a little bit, because clearly you have to be able to slide and insert and leave the IUD in the uterus. Okay. And we'll talk about that in a second. Cytotec taken orally. If you're inducing labor, you can use it intravaginally, but generally speaking, and you could do it intravaginally, I guess, for an IUD as well, but I think it's just a little bit more tolerable to take orally. And there are 2 different versions that you would use, like you wouldn't use the vaginal version for the oral. You get what I'm saying. But you would prescribe that, and I would have ladies take it 3 hours before they came, because I want that cervix to be nice and relaxed and have a little bit of dilation, a little bit, like a fingertip to 1 centimeter. When you're having a baby, you want like 10. We want like that much, so that it's more gentle and more comfortable for me to place the IUD. So those, I think, are 2 big steps prior to coming to your visit that make the day of the procedure significantly more comfortable. Significantly. Less pain and cramping, less pushing and pulling and prodding during the procedure, much more ease when it comes to the provider being able to kind of place things, much more comfortable. And I think those things are probably the biggest things that a lot of women have not had the option to do, or maybe some providers weren't trained to do it that way, but that's the way I learned about it, 2004 in residency at UNC. And that's been the way I've done it ever since. And people tend to have positive feedback from that. So again, at the time of scheduling the appointment, go ahead and prescribe the prescription strength ibuprofen with the directions to write 1 tab an hour before coming in for procedure. And then Cytotec, I think it's 400 micrograms. You take 3 hours before the appointment, so that when they come in, the cervix is already relaxed and slightly dilated. Okay. Does that make sense? Prior to, they say they take their Cytotec about 3 hours before they come in for the appointment. Clearly, you may have a little bit of spotting, a little bit of cramping, because what's happening is that cervix is moving, that tissue is moving and it's dilating, and you may have a little bit of crampiness with it. Okay. And it is reversible, by the way. So once we're done, with the procedure, the cervix goes back to its normal opening. Okay. All right. I'll pause for a second. Make sure you don't have any comments or questions, and then we'll talk about how we do it. All right. Good. All right. So, they come in for their appointment. They've taken their ibuprofen. They've taken their Cytotec. When they came in for their day of, I would ask them, hey, did you take your Cytotec? Did you take your ibuprofen? If for some reason they forgot to take their ibuprofen before they came, I would go ahead and just give them ibuprofen. We had ibuprofen in the office. If they couldn't take or tolerate ibuprofen for some reason, I would give them Tylenol. Tylenol is also good if, say, they did take their ibuprofen, we placed the IUD, and they had a good bit of cramping or discomfort right after placement. I would go ahead and give them some Tylenol ahead of time, because if you're taking your 800 ibuprofen, you can't take another dose for another 8 hours. But in between, you can take some Tylenol. So I would give them Tylenol before they left the office if they were already feeling uncomfortable. So here's our fake uterus. Here's our Mirena IUD. So they would come for the appointment. We'd have to get a urine pregnancy. Got to do a urine pregnancy to make sure everything is negative before we get started. Make sure that, of course, they don't have any infections and all that. Hopefully you did that during the time that you were talking about when you were going to place the IUD. Come in, they get set up, of course, sterilized, speculum, so we can visualize everything, right? So again, it's probably more for my medical colleagues than anything, but things that I think helped to make the patient more comfortable. Number one is that I always had a medical assistant or another person with me to hold the patient's hand, to be at the head of the table because I was at the foot, to talk to them, to make sure they were okay, to answer any questions, to help them take deep breaths if they need to. I think that really helps to have another person. If they, didn't bring someone with them, maybe they brought their spouse or their partner or their parent with them to do the procedure, and they have somebody to kind of talk to and keep them relaxed. If for some reason they didn't bring someone, or I didn't have a medical assistant that could stay in the room the whole time, then if they had their earbuds, or they had their music, have them listen to that. Some of them would be watching something on their phone, watching a movie, something to kind of distract them so they weren't really thinking about what was happening, right? So they're set up, sterilized instruments, everything's sterile. First thing you have to do is what's called sounding. And sounding means measuring, not only kind of opening the door a little bit to the cervix, but measuring the length of the uterus. Most uteri, non-pregnant, are probably 4 to 5 centimeters from the cervix to the fundus, or the very top. So with your sound, what you're doing is knowing how far you're going to go, right? So usually it's metal. I don't have a metal one. This is a plastic one. But a metal sound helps you to measure how far up you're going to go before you release the IUD, the top of the fundus, okay? That can cause a little bit of cramping because, again, you're opening that door that is not supposed to be open. But if they took their Cytotec, it's going to be a little bit more relaxed and it's not going to hurt as much, right? But what I would tell them is, I would say, okay, we're going to do sounding. I'm going to measure the length of the uterus. You might feel a little bit of cramping, so take some deep breaths. And we'll kind of slowly make our way to the top. I guess I could use this, huh? We would slowly make our way to the top. And you go, oh, don't do that. Don't go through it. Don't do that. So that's a complication. But once you hit the top, that's how far you're going to go. And then you come out. Where the line is on the sound, and metal sounds actually have, little markings that tell you, 4 centimeters, 5, 6, 7, 8. Most of the time it was 4 to 6 centimeters long that you would go. That tells you how far your device needs to go to reach the top. So let's say we went all, to this edge here with our sound. So that means I'm going to pull this down to here, because that's how far or how long the uterus is. Okay? All right. Taking this out. So you remove the sound, and fairly quickly right after. So you don't want to wait too long after sounding, between sounding and placement, because you don't want the cervix to kind of close back up. You want it to kind of stay there so you don't have to push too far again. And again, this is after doing all your you have to wipe things with, your liquid. You have to, what's it called? I think I have some here. You have to sanitize everything. So you have to wipe away, any extra mucus. You have your solution that you have to sanitize and get everything all cleaned with. So you've done all that prior to this, by the way. Okay. I'm skipping steps just because you all need to know that. All right. So now we're ready. We've sounded, we've come out, we've measured. We know that we're ready. All right. We're sliding into the top of the uterus. And with this lever here, this is specifically Mirena. They're all a little bit different in terms of what they look like in the device and how to release it. But once we release it, and again, this demo isn't the best because it has a little opening at the top. I'll hold it like this. Release it and push to the top. Make sure it's up there. And then you want to slowly, this probably won't stay in, but if this were a real body, this would stay. And I would slide the device out. Okay? Again, telling the patient to take deep breaths. I'm watching or trying to watch their face, or my assistant is watching the face for any grimaces or any struggles with pain, because you can stop and take a break. You don't have to push them to the point of exhaustion or the point of extreme pain. If they're having a cramp or they're not feeling good and you can stop, you can pause and let them catch their breath. Okay? But you push all the way to the top and release. Once you've released, and I don't want to take it all the way out of the device because I'm going to put it back in. There's string left. So these are the strings that people are always talking about with IUDs. These are the strings. They're kind of they're more like a metal filament is what they are. But these strings here, they don't hang outside of the vaginal cavity like tampon strings. They actually, probably only about that much, stays right outside of the cervix. Let me show you. It's probably about that much. And when you first get your placement, can you see it? Put it on my face. When you first get your placement, I'll usually leave the strings a little bit longer than I normally would keep them, because there can be shifting and adjusting. Right after they have their IUD placed, your uterus is going to contract, it's going to move, it's going to try to push that foreign body out of the body because it's not supposed to be there, right? So you want to give it a little bit of space to move and glide. Those strings are important for visualization. So when they go and get their strings checked, which I didn't always do unless they needed to, unless they were getting their annual physicals and checkups, then I would look with the speculum and be able to see the strings and say, yep, it's still there, it's in the right place. But also clearly it's there for when it's time to remove it. Okay. Later on, if the strings are too long, if their partner can feel it during intercourse, or it feels like it's curving and sticking them, you can always take your long scissors. I think I have some long scissors. Do I? I may not. They look like this. This is a forceps, but they look like this. You take some long scissors and you clip the strings and then remove the ends of the strings, okay? And then that's it. Remove the speculum and you're done, okay? Most of the time, particularly or especially if they took their ibuprofen and their Cytotec beforehand, they're good to go. Occasionally, if they're really sensitive or just really having bad cramping, I let them rest, take the speculum out, take their feet out the stirrups, let them lay flat and just kind of relax for a little bit. If they need ibuprofen, if they need some water, some Tylenol, depending on what they took before they came, let them chill, make sure they're okay before sitting them up, standing them up, and getting them dressed, because you don't want them to shoot up too fast and then they've passed out because they're dizzy or they're in pain. And that's it. I mean, I hate that it's, for a lot of women, it's much more complicated than that. I'm trying to think of other tricks. The other trick, so notice, and for ladies that have had this done, or for my medical folks that have done this a lot, I didn't talk a lot about grabbing the cervix because, knock on wood, again, toot my own horn, pat myself on the back, I didn't have to do that very much. And I think it had a lot to do with pre-medicating with the Cytotec and softening the cervix so that the sound and the device would gently go through. The times that I did have to use what's called, I have ring forceps, but I have the tenaculum is this. The tenaculum, times that I have had to hold the cervix still. So, visualize this as the face of the cervix, that's the endocervix, or, the part that dilates. Sometimes you have to grab on and hold the cervix still because it moves. It's tissue, so it moves. Times that I have had to do that is when I had a lot of trouble advancing the sound, or it was just really, really closed and tense and gave me a lot of resistance with sliding the sound in the device. And that can be uncomfortable. They can feel crampy because it's a metal, it's sharp, right? Let's take a look. For men that have no experience, let me look at that, right? So that's sharp, and it clicks and it holds, right? So you can hold things in place. Things that would make that part more comfortable was, Charmaine says post placement, that's making me crazy. Okay, yeah, we'll talk about that too. What would make the tenaculum placement and all of that more comfortable for my folks is, number one, I would either have them do what's called Valsalva, which is kind of either a deep breath and a bearing down, or a cough right at the time that I was clamping, because for some reason the body is distracted. Your heart rate kind of drops a little bit, kind of resets, and your body is just distracted from thinking about the pain, and it's very quick, so it doesn't last very long. So as I'm getting ready to clamp, I would go here, and I would say on the count of 3, you're going to cough 3 times in a row, or you're going to Valsalva. And on 1, 2, 3, they would cough, 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 and I would hold it. And then that was that. And that would help you to hold and slide at the same time, and then you could take it off. So one way you can do it. The other way that I've seen people do it is, actually there are 2 other ways, is with lidocaine. Either you can spray, there's a lidocaine spray that you can use, or that you can inject with a needle. Lidocaine, no epinephrine with it, just lidocaine. You can use a needle extender, and at 11 and 1 o'clock, you place a little bit of lidocaine there, a little bit of lidocaine there, just to numb up the surface of the tissue, just like you were getting a filling, and then place your tenaculum, and that would make it more comfortable. Again, in 15 years, I only had to use the tenaculum 10% of the time, and that was because the patient had taken their medication, or thankfully it was just an easy insertion advancement with the sound and not a big deal. The other thing, this is an asterisk to doing your pre-scheduling, pre-planning, pre-medication, is you can have the patient come on the last day or right after the period, because the cervix will dilate a little bit, of course, as they're having their menstruation. So, if you catch them on the last day of their period, if they know ahead of time and know on their calendar when their period is, they can schedule for the day of the last day of their period, or the right after that, so that things are more relaxed. Okay. All right. What else? So that's insertion day. Insertion day, women usually jump right up, go back to work, go home, do whatever, and go on about their day. I would tell them, continue taking your ibuprofen if needed, use your heating pad if needed. You will have a little bit of spotting because we've been messing around all this tissue. So you will have a little bit of spotting, but you should not have any blood heavier than a period. If that's the case, you need to call us back. You shouldn't have any foul smelling discharge. If you do, you need to call us back. And I would generally tell them not to have intercourse for a couple of days. That part I can't remember. I don't know if I would tell them 3 to 7 days. I think I would tell them if they were planning on having intercourse soon after their placement, that they should use a backup method. They should use a barrier method, a condom, a diaphragm, whatever, so that, you still have to give it time to kick in and work. And that was with any birth control that a woman was just starting. You need a couple of days or so that it can kick in. Okay. Cause you're using it for birth control, and that's not the time you want to get pregnant. Right. All right. Any questions? I'll take a pause, and then we'll talk about removal. All right. So my friend Charmaine says the post placement. So hopefully things like, again, the pre-medication beforehand, which can hopefully have a long lasting effect on the relaxation of the tissue, having the ibuprofen on hand that you would take, around the clock if needed, with Tylenol in between. And then of course, if you're having too much pain or too many things don't feel right afterwards, you definitely have the option of going back to your doctor. Some folks, I guess, will schedule a week after placement just to check in with their folks. I would just tell people to call me if they have problems, and they almost never had problems. But then, of course, at their subsequent their follow-up appointments, I would ask them how things went and how they were feeling. Removal. So your removal can be done pretty much anytime. So there's really no pre-planning, pre-scheduling, pre-medication. Usually I would have my folks during the time of their physical and their pap smear to say, okay, you know what? You've had your IUD for 6 years now. You want to go ahead and take it out? And they're like, yeah, while you're there, go ahead and take it out. So that includes putting your speculum in, of course. You don't have to really do a whole sterile procedure, just like you wouldn't necessarily do everything with a, surgically for a pap smear. Putting in your speculum, as long as you see the string, you're good to go. And these are called, again, usually they're metal, ring forceps, because this grabs the string. All right, so you know that you have that string that's sitting outside of the cervix. You can see it, hopefully. You look at it. Can you see? Do you feel your strings? I can see them. Okay. All right. What I do is I would grasp here with the ring forceps. And remember that Valsalva that we did when we placed it? Same Valsalva I would ask them to do. And as they coughed 3 times or took their deep breath and bore down, I would slide it right out. That's it. I mean, that's it. I don't know. I hate that so many women have had so many negative experiences, but cough, 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 Valsalva, slide. Now, there are some instances where the arms of that IUD, because especially if it's lived in the uterus for a long time, it'll hold on to the muscle inside the cavity. Like it'll, it creates itself a little home. It sits there, right? It may embed itself a little bit. Sometimes that's hard to pull out, and that can be uncomfortable. And they'll say, ow, you're trying to pull and it's not really coming out. If it gets stuck, again, don't put the woman through all the suffering. I say you have a question, but can you have peri-symptoms with the IUD? Okay, I'll come back to that. Sometimes either you can't see the string at all, like it's advanced and it's kind of sucked up high into the uterus, or rarely does it just fall out. I mean, that's rare that I've had somebody say it just fell out. Rarely that's ever happened. But you can't see the strings. You're not sure if it's still there. Hi, Chrissy. Or it's too painful to take out, or you don't want to pull so hard that the patient is in extreme pain. In those cases, I will send them to GYN to have another procedure done where they can make the patient more comfortable. They can numb them up. Sometimes, rarely, they have to take them to the OR. But they'll usually do an ultrasound just to locate where the IUD is and say, yes, okay, the IUD is still there. It's over here in that upper right quadrant or wherever. And either they'll go in and they'll dilate more and then grab it, or, like I said, rarely they have to go to the operating room and numb people up and take it out, but that's rare. Okay, so let's get to questions. Let's see, what else did I miss prior to that one? I think that was it. So hopefully that answered a lot about post-placement and removal. Can you have peri-symptoms with the IUD, meaning perimenopausal? Yes, although I did have women that chose to keep it up until their mid-40s on purpose, particularly if it was Mirena or Kalina, the one that has the progesterone in it, to help them with perimenopausal symptoms, because it was giving them some form of hormonal control. Now, the copper IUD, because it has 0 hormone, you're going to feel what your natural hormones will do. And by the way, along those same lines, generally speaking, IUDs don't change your periods. Asterisk. Copper IUDs, you usually will have your normal monthly or however regularly you have your menstrual cycles. The progesterone containing ones, sometimes you will have a change of your frequency, or sometimes you won't have a period at all, right? So everybody's different. But generally speaking, if you choose the copper IUD, it doesn't change your hormone level. If you're looking for help with things like menstruation, fibroids, perimenopause, menopause, some women will keep them up to their early to mid 40s for that reason. Okay. What else? I think that's it. that was fun for me. It was a trip down memory lane. I have considered, I don't know if I want to say that. Might get me into trouble. I've considered going into a clinical situation where I would just do IUDs. Like not do the other stuff and see patients, but just do the I often miss the procedural part because I was pretty good with my hands when it came to procedures. So I think about that sometimes because I'm sad to say my beloved practice is no longer doing them. Well, I don't know, they might be doing them now, but when I left for a couple of years, they weren't doing anything IUD related, and that made me sad. I tried to teach them, but I mean, there are some nuances. You really have to be comfortable with it for you to do, the more you do them, the more comfortable and the more easy it is. But you do have to practice. So I guess they never felt comfortable enough to do them. Okay. But that's it, y'all. I didn't want to overwhelm you. So I just wanted to, if for nothing else, document how I did it before I forgot, because I've been out of clinical practice for a couple of years in case I ever go back. Or share my tips and tricks with my medical folks that have been having issues with doing them, or sharing this information with patients so that when you go to your doctor and ask for an IUD, or you're about to get a new IUD and you're switching it out, you'll say, hey, I talked to Dr. Swiner and she talked about Cytotec and ibuprofen. Do you pre-medicate your folks? Ask them. You can ask them about that. You can ask them for that. Okay. Family docs can and do IUDs, and there may be some pediatricians, depending on the age, of course, of the patient, that do IUDs as well. But clearly your OBGYNs, your Planned Parenthood, your folks that do a lot of women's health and labor and delivery do IUDs, but so do your primary care folks. So you can go to your primary care people and have that discussion with them. Okay. I will keep this. I will save this on my Instagram Live and Reels so that we can go back to it. I'll also put it on my YouTube channel so folks can view it there and ask questions, and hopefully that helped. All right, y'all be safe. Bye.